Well, hello everyone, and welcome to this webinar related to some new insights into modern scleral lenses. I'm delighted to be here with you today and want to thank our sponsors, of course, Precision Technology and Cardinal Contact Lens in Canada, for sponsoring this wonderful opportunity for all of us. Now, this is going to be a bit of a review of a specific scleral lens design called the ICD. The ICD is really the brainchild of the KATT Inc. Lens Design Group, one of the earlier groups to begin the development of modern scleral contact lenses. As we know, these lenses have had a pretty dramatic impact on our contact lens practices, in our normal practices. They've been used predominantly in two situations, ocular disease and the correction of irregular astigmatisms. Irregular astigmatisms when we can't get a corneal contact lens to perform well. Now, one of the real fundamental questions that we have to ask ourselves is why the rebirth of scleral lenses? We know that historically these lenses go back to the earliest contact lens ever made, 1887 by Friedrich Muller in Wiesbaden, Germany. Of course, that scleral lens was made of glass, and the reason scleral lenses stayed all the way up to the mid-1940s was related to the fact that the glass was very, very heavy. And then with the advent of PMMA, a lighter lens material, the issues of oxygen permeability became prevalent with these scleral lenses. And for many, many years, these lenses were put by the wayside. And today, now they are back. And it's kind of neat to just take a look at what brought these lenses back. Predominantly, it was the fact that they could be used on a wide range of corneas in which we were unable to get rigid contact lenses to work. Now, we teach our students at Pacific University that we're going to differentiate whether we're going to use a corneal contact lens on a patient or a scleral lens by activating the elevation display map that we see on the right. The elevation display map is a critical display. It tells us where the cornea is highest, where the red is, and where the cornea is lowest, wherever the blue is. With that information, we can move our cursor around very quickly, identify the high spot that is 180 microns higher than a spherical surface. We can find the low spot in the cornea minus 110 microns. We just simply add those two numbers together, and we see in this example that there's a height differential in this particular cornea of 290 microns. Well, our data at Pacific University has shown us very clearly that if that number is under 350 microns, that there is about an 88% chance that we're going to be able to adequately manage this patient with a corneal GP lens. So we could see here on that particular cornea, the simulated fluorescein pattern along the horizontal meridian and along the vertical meridian. And sure enough, when we apply that corneal contact lens, we see the lens landing on the red. where the cornea is the highest. That is the first point of contact of the contact lens. And you can see it in the fluorescein pattern starting at about 5 o'clock, moving up, and around 12 o'clock, coming down to about 7 o'clock. So we could see here very, very clearly that we're going to have a stable contact lens by virtue of that large peripheral landing area. Yes, the lens is going to lift off over that blue lake down below, but nonetheless, the height differential in this cornea is within a realm whereby a corneal GP lens is going to function quite well. Now, let's take a look at this cornea and put it through the same exercise. The highest spot, the lowest spot, and now our height differential is 655 microns. Well, these are the eyes that we have to place into a scleral contact lens, because these eyes, it's very difficult to get a corneal contact lens to land adequately in a cornea that has that much height differential to it. So this is where scleral lenses have really come to the forefront in this ability to overcome all of these height differentials. With the 300 microns of clearance we're trying to generate beneath these lenses, we can accommodate a wide range of height differentials in these corneas and do it and making the contact lens extremely comfortable. Now, if you don't have a topographer that provides you elevation data, all you need to do is look at the fluorescein pattern. Here we see 6 fluorescein patterns of lenses I have fitted over the years. All 6 of them look absolutely terrible. These are disgusting fluorescein patterns, but they're very representative of what we would see when we have a significant height differential in the cornea. We're going to get areas of the lens radically lifting off. We're going to get poor landing of the contact lens peripherally. And these are going to be very uncomfortable lenses for the patient. So virtually all of these eyes would probably best be served with some type of scleral lens modality like the ICD FlexFit. Now, let's take a look at comfort. This is a comfort study we performed at Pacific University, in which we were looking at 2 different scleral lens designs. The important exercise here for me was that when these lenses were applied to individuals who had never worn a contact lens, what we see here is that the average comfort on a 1 to 10 scale was 8.5, with 10 being I physically can't feel it on my eye. And you could see when we use these same comfort scale scoring charts with corneal GP lenses, the comfort level is down in the area of 2 to 4. So we can see here that this is quite amazing, because when we do this once again now with modern silicone hydrogel lenses, the average score on these individuals was 9. So this was amazing to us that we actually had a rigid lens modality that had comfort features similar to that of a soft contact lens. Very, very exciting to see in our modern times. Now, another study we did that I feel was very, very insightful to me was this particular study in which we looked at how much tear exchange there is beneath a modern scleral contact lens. Well, at the end of this study, we found that that number is very, very close to zero. There is little or no tear exchange beneath a modern scleral lens. Well, why is that? Well, these lenses, when they're applied to the eye, actually rest or sink into the bulbar conjunctiva approximately 127 microns. And what that does is it virtually creates a watertight seal beneath the contact lens. You wonder why these lenses have performed so well in individuals with pathologic ocular surface disease. Well, this is the reason. Whatever fluid we place into the back of the contact lens is going to be there throughout the entire day. So these corneas that have pathologically dry surfaces, their surface properties are maintained by the presence of this very closed fluid-filled system. So once again, a very kind of exciting thing that we have this kind of modality that has this many features to it. Just an example of that is this patient with Stevens-Johnson syndrome. As you can see here, the patient on initial presentation had a corrected visual acuity of 2400. Now, after applying the scleral lens and wearing it for 6 months, this is the same patient, the same eye. Now, the only medical therapy that this patient was on was the saline trapped beneath that contact lens, that preservative-free saline. It just goes to show you the response of many of these corneas with severe ocular surface disease, the virtual miracles that take place beneath these lenses in surprisingly short periods of time. Now, we believe that another key ingredient to the rebirth of the scleral lens was the advent of the modern high decay scleral material. And here is a pretty up-to-date list on where we are at with the various lens materials. You could see the new Contomac Infinite has just been released a few months ago. It has a decay similar to the Menicon Z. But as you can see, these lens materials all have decays of 100 or in excess of 100. So we know that these lenses are incredibly comfortable. We know that they create a semi-closed fluid-filled system beneath themselves, and that we have these high decay materials, which are a great asset for the long wearing periods these patients have with their lenses. Now, perhaps one of the most important features that came about with time was a better understanding of scleral shape. You know, when I was in school many, many years ago, we were taught that the cornea had a curved surface to it and that the sclera had a curved surface to it. And these types of drawings became, you know, fairly prevalent. But today we know that these drawings are somewhat inaccurate. They're inaccurate because the cornea does have a curve, but that curve stops at about a chord of 10 millimeters. And then from 10 millimeters out to a chord of approximately 20 millimeters, the eye forms a relatively straight line or tangent. And you can easily prove this to yourself tomorrow or whenever you get back to the office. Just have the patient look down and you'll see it forms an almost perfect tangent or straight line. Now, this was very, very critical to our understanding of modern scleral lens designs, because historically we had always used curves in the periphery, thinking that the sclera was a curved surface. Yes, it is, but that curve doesn't start until after a chord of 20 millimeters. There you can see the eye finally beginning to make its curved shape. So modern OCT imaging provided us some tremendous insights into modern scleral lens design, in the fact that we would probably align that area of the sclera best by not incorporating a curve, but instead a tangent angle. And that was the evolution of the modern ICD FlexFit lens. This is a lens that incorporated a series of angles or tangents in the periphery to create the desired clearances we need in the contact lens. The only curve of the contact lens is actually in the center 9 to 10 millimeters of the contact lens, and that is that base curve radius. Beyond that, it just goes into that all-important straight line or tangent angle. What this did is it almost completely eliminated this lens tightening, which was so prevalent in our earliest modern scleral lens designs. Today, these really make up about 4 different portions of the lens. The anatomical features are things we're going to be discussing here in great detail in just a few minutes. By now, we all know that scleral lenses, like the ICD, are fitted by sagittal height. And that is, we're going to not match the curvature of the cornea, but we're going to vault over that portion of the cornea with our scleral contact lens. So, how do we start? How do we begin the fitting of a modern ICD FlexFit lens? Well, let's take, for example, this particular patient. No doubt about the diagnosis here. We have a patient with filamentary keratitis who is experiencing a lot of discomfort with their ocular surface disease. Now, what we're going to do is go to our FlexFit diagnostic set. This diagnostic set comes in 2 diameters, 14.8 and 16.3. Now, the word FlexFit is really based on the principle that these lenses can be increased or decreased in diameter by just simply communicating to the laboratory the lens you have on, and you want to flex the diameter and make it bigger or smaller. In many cases, the 14.8 and the 16.3 are perfectly adequate. But having that little extra ability to increase the 16.3 millimeter lens to 17 millimeters or decrease it to 15.5 is really a wonderful feature in the contact lens. It is a straight calculation that is made by the laboratory and by the lathe that allows you to diagnostically fit the contact lens with the 16.3 or 14.8 and then maintain that same sagittal depth when you increase or decrease the diameter of the lens. So here we can see three different lens diameters, the standard 14.8, and we see how we have flexed it to 15.1 and 15.4. And you can see here very, very easily that the sagittal depth of the lens has not changed at all. But we've been able to increase the diameter or decrease the diameter as we deem clinically appropriate. Now, one of the real features that I like to use when kind of differentiating where to start with the 14.8, with the 16.3, is really visible iris diameter. And the best way to do this little calculation is to measure visible iris diameter and simply add 3.5 millimeters to that number. So in the example on the left where we have an 11 millimeter cornea, we add 3.5 millimeters, it's 14.5. And the closest diagnostic lens diameter would be 14.8. Now remember, we can flex down to 14.5 if we deem it clinically required. And same thing is true with this lens over here, with the corneal over on the right with the 12.5. And here again, we'll select our closest diameter, the 16.3, with that ability to flex up and down. So to me, this is one of the strongest features associated with this design. Those tangent angles in the periphery that avoid that peripheral tightening, the ability to flex the diameter of the contact lens up and down really gives the clinician a tremendous amount of leeway in the fitting of normal eyes as well as our all-important pathologic eyes. So here we're going to take a quick look at the diagnostic set and choosing the initial lens for our patient. Remember, we have the small diameter and the large diameter lenses available. These lenses are very frequently fitted by diagnosis. That is, we anticipate that this patient with filamentary keratitis is going to have a relatively normal sagittal depth. They have not had any other type of pathology other than surface disease. They are not keratoconic, postcorneal transplant, pellucid. They are a relatively normal sag. And in that situation, if we're going to use the 14.8 diameter, we would select the sagittal depth of 3,400 for the 14.8, and for the 16.3, the depth would be 4,000 microns. Now, if it's a patient with early keratoconus, you can see here the two lenses and the two diameters. And with our pathologic eyes, no doubt we have found that we get our best clinical performance with the 16.3 diameter lens. So here we have 9 diagnostic lenses to select from in our ICD FlexFit set. So now we have this tremendous ability to create that desired lens clearance we're after. So in our patient with the normal sagittal depth. This would be, or I should say, these would be the lenses that we're going to place on the patient. We fill the lens with preservative-free saline. We add our fluorescein, and now we just basically rest the lens on the eye. Now, this used to be fairly easy and straightforward, but a little tiny level of complexity has been added because of the advent of some new saline solutions. Now, initially, the solutions that were used were the Adipac solutions and the Purolens solutions, both preservative-free saline solutions. But now we have some additional saline solutions. Now, it's important that we understand why these other salines appeared in the marketplace. And really, it has to do with this little feature, and that is the pH of the preservative-free saline solution. This is a study we performed at Pacific University where we measured the pH of many of these salines, or the ones that were available at the time of the study. And you can see many of them are very near that physiologic pH of around 7.0. But you'll notice that this Adipac, the hospital grade saline solution, has a pH of 5.3. Now, it was interesting because what we learned clinically is that our patients with dry eye frequently had problems with that pH solution, the Adipac solution. And when we went to a buffered saline solution in the back of the lens, we noticed a rather significant improvement in their comfort. So here is a study we performed at Pacific. It's just a pilot study, but it gave us some pretty good information. And that is the fact that the buffered saline solution, when used 2 weeks, and the non-buffered saline resulted in some different results in these dry eye patients. We had the patient fill in a dry eye questionnaire, and as you can see here, the baseline score of that dry eye questionnaire was 41.6. Now, when they use the buffered saline for 2 weeks, obviously the sheer presence of the scleral lens improved rather dramatically their dry eye symptoms. And you can see here the buffered saline solution did perform a little bit better. Now, that's not the important part of this little evaluation. The important thing was that 5 out of the 6 dry eye subjects preferred the buffered saline solution, and given a forced choice, 1 patient had no preference between the 2. So this was pretty insightful to me, that with patients with ocular surface disease, dry eyes, post-LASIK, they may be better served with one of our more modern preservative-free buffered saline solutions. Here are some of those that are currently on the market, and the other is the Purolens, that is also a pH balanced solution. So we do have some wonderful products to choose from. And since we did that study and adopted this new philosophy, we have definitely served our patients better, especially our dry eye patients. Now, let's look at the anatomy of the ICD FlexFit, because so far what we did is we took this patient with filamentary keratitis. we placed on a scleral lens with a buffered saline solution, and now we need to evaluate the fit of the lens. Now we're going to do that by starting out at the center of the contact lens, and we're going to look at the amount of central vault that we see beneath the lens. Now we're targeting 250 to 400 microns of apical clearance. Other practitioners have other targets that they like to shoot at, but this is the one that we have found performs well for us clinically. We evaluate that by looking at the lens in optic section, where we're able to see the thickness of the lens, which is approximately 300 microns thick. We're looking for approximately 300 microns of apical clearance. And here you can see with slit lamp and in OCT imaging the vaulting that we're really searching for. Now, the reason for the excessive amount of clearance, call it 300 microns, is the fact that these lenses are going to settle in. They're going to sink in to the bulbar conjunctiva. And while they're sinking in, they're compressing these rather enormous goblet cells that we see here. And all of this is resulting in a settling effect of the lens that today we estimate to be around 130 microns. So in this particular patient, where we started off at baseline with 400 microns of apical clearance, we can see that following 8 hours of lens wear, this is now decreased to 270 microns, or 130 micron decrease in the apical clearance, secondary to the settling effect of the lens. Something new for us in the contact lens industry. We never had to think about this when we were fitting corneal contact lenses. Never had to consider it when fitting soft contact lenses, this settling effect. But scleral lenses are different, and therefore this needs to be worked into our equation. Now we're going to adjust the height of that central radius of curvature by increasing or decreasing the sagittal depth of that diagnostic lens. And once again, with optic section, it's so easy to get an estimation of the amount of clearance you have in the central cornea. It's very, very clear which direction you'll need to go. Now, perhaps the curve that is most critical for me clinically is this peripheral corneal clearance zone, the PCCZ. Now, this is that first tangent, that first angle after the base curve of the contact lens. And this is the one where we're going to need to adjust, usually to create a little bit of additional clearance in individuals. Here we see a lens at dispensing, and you can see the faint thinning of fluorescein in the area of the peripheral cornea. Now, if we leave that and let that lens settle in, we could see how exaggerated that actually becomes. And that will inevitably result in this peripheral corneal staining that we see right here. It's a kind of peculiar kind of staining we see. It's a real coarse punctate staining, but nonetheless, oftentimes related to the inadequate peripheral corneal clearance. Now, we're going to see this most, believe it or not, with corneas of larger diameter. In those larger diameter corneas, greater than 12 millimeters, we frequently have to lift that peripheral corneal clearance zone to create the desired clearance. Well, this is what it looks like. The FlexFit has this ability to create this additional peripheral clearance. We see here in this image on the left a eye that has some early evidence of fluorescing thinning near the limbus. And we're going to communicate to the laboratory that we want to keep the base curve radius the same, but we're going to increase the peripheral corneal clearance zone 5 steps. Now, why 5 steps? Well, 5 steps is going to give us 125 microns of additional peripheral corneal clearance. We have found in our experience that to really create a clinically significant change in that clearance, that we need that 125 microns. Now, the way the numbers work is that each step is an increase in 25 microns. So if we want to increase the depth of the lens, we think of it as sagittal depth. And that means it's a plus number. So we're going to add +1 to increase that clearance 25 microns. But again, to create a clinically significant change, I'm going to really go to a +5 and create 125 micron change. What that will do is it will create that image we see here on the right. And that is a lens with adequate peripheral clearance. Now we can play around with that peripheral clearance zone, whereby if we feel that adding 125 microns to that apical clearance is going to create an excessive amount of apical clearance, we can then order the contact lens with a flatter base curve or less sagittal depth, and that will create a better overall fitting relationship. So all of these are simply adjusted with that tangent angle, moving it up, moving it down. Perhaps the best way to think of this is like a drawbridge. You know how a drawbridge just it goes up like this, it goes down like this? That is exactly what is happening with an ICD FlexFit lens. We're just simply changing the angle to increase or decrease the clearance of the lens. What is fun to do as well is to create an oblate lens, call it reverse geometry type of configuration, in which we can use a flat radius of curvature in the center, a relatively steep peripheral corneal clearance curve, and look what you've created. You've created a beautiful oblate construction if it is required for one of those plateau-shaped corneas following penetrating keratoplasty or following refractive surgery. Now, another new curve for us in the contact lens industry was this limbal clearance curve. Shouldn't call it a curve, a limbal clearance tangent angle. Now, this is something we learned inadvertently with scleral lenses. Not only did we need to clear the apex and peripheral cornea, but we learned we needed to clear the limbus as well. Now, I like to view this limbal clearance best with the white light of the slit lamp. It allows me to see exactly where the cornea stops, where the limbus begins, and when I see that, call it bleeding of fluorescein over into that area beyond the limbus, I know I have created my desired limbal clearance. This really then takes all the weight and bearing of the contact lens and places it on the scleral landing zone. So you could see here, we need a scleral lens that clears the central cornea, clears the peripheral cornea, clears the limbus, and then ultimately lands on the sclera, or better yet, on the bulbar conjunctiva at the periphery of the lens. Now, here is a just lovely example of a lens with inadequate limbal clearance. We could see here that the peripheral cornea has been kind of affected. But when we look over at that area beyond the cornea, that limbal area, we see very, very little fluorescein there, indicating we probably have a situation where we have inadequate limbal clearance, resulting in inadequate peripheral corneal clearance. So here we're going to begin first on the outside and work our way inward. We're going to create our desired limbal clearance, and now that is going to lift the entire contact lens off of the eye. So when you're looking at that thinning of fluorescein in the peripheral cornea, be sure to look at the adjacent limbal clearance, because lifting just the limbal clearance is going to lift the entire contact lens. It's going to lift and create the limbal clearance, the peripheral corneal clearance, and additional apical clearance. Now, just as with the peripheral corneal clearance zone, the ICD FlexFit and its limbal clearance zone works in the same numeric values. A +1 is going to increase that angle 25 microns, a +5, 125 microns. And here again, for me, clinically, I'd like to work in these larger increments to begin with. I'd like to work in these 125 micron increments where I can physically see a clinical change taking place in the fluorescein pattern. Now, where you're going to be jettisoning both the limbal clearance and peripheral corneal clearance is in these individuals. These are individuals that have enormous sagittal depths. And you could see here that we're going to need a contact lens with a very steep limbal zone, a very steep peripheral corneal clearance zone to create the desired clearance in the lens. We can see the ICD FlexFit on this patient in that center slit lamp image, and it indeed has created that desired clearance. Now, once again, we're going to evaluate this and see, do we need to make some additional subtle changes to the contact lens? Do we have adequate clearance 360 degrees around on this bulging graft? And here we could see that, well, maybe not. Here we're going to want to increase that a little bit more to create that clearance over that highly elevated spot in the peripheral cornea. And here we're going to go up an additional +10 in the peripheral corneal clearance zone, which is going to elevate the depth of the contact lens an additional 250 microns. When you're going through these changes in your head, remember this crazy little image down below, that drawbridge. I'll tell you, that drawbridge in my mind is there every time I'm fitting a ICD FlexFit lens. I'm constantly doing this in practice to really get my arms around what is happening clinically. And here is this particular patient in OCT imaging, and sure enough, you could see that we've created the desired clearance we're really looking for in this particular patient. Finally, the lens needs to land on the cornea somewhere, and of course that is the Scleral Landing Zone. This is an elaborate edge design that's been incorporated into the periphery of the ICD FlexFit and allows for this landing to take place over a fairly wide area and allows this gentle resting of the contact lens in the periphery. Now, as you can imagine, when we're flexing these diameters, it may be necessary to make some fine-tuning adjustments in the periphery. Now, here is where I deviate a little bit, because remember I said before that when dealing with the peripheral corneal clearance and limbal clearance zones, we work in larger 125 micron increments. Here we work in small increments. And here, because we're usually loosening the contact lens, as we loosen it, the depth of the lens decreases. As we increase an angle, it increases in sagittal depth. So here we have a minus numeric number. And here I would work in 1 degree increments. I would order this contact lens a -1, which would increase the flattening of the lens by 25 microns. So we work in these smaller increments in the periphery of the contact lens. So remember, if we're going to flatten the Scleral Landing Zone, we're going to decrease the depth of the lens, as we see here in this image, whereby if we're going to tighten the periphery of the contact lens, we're going to increase the sagittal depth of the contact lens, be it a small amount if we're dealing in 25 micron increments, but nonetheless, it's going to follow this kind of numeric pattern. Once we've established the physical fit of the lens, an over-refraction is performed, and we are ready to order that contact lens. Well, here is our patient with filamentary keratitis, and now we're going to look at that patient 2 weeks after wearing the scleral contact lens. What a dramatic improvement we see here in this individual. So These lenses work virtual miracles in relatively short periods of time for many of these patients with ocular surface disease. Now, I did want to make you aware of a couple markers that are incorporated into the diagnostic lenses in the ICD FlexFit diagnostic set. The 14.8 has these little markers that are placed exactly in the area of the limbal clearance zone. So we can see here, does that area, those black markers, do they actually clear that area of the limbus? And the 16.3, of course, has its markers along the flat meridian, and I'll explain that to you in just a few minutes. But here is a small diameter cornea, and you can see where the markers line up. You can see that the markers are right over the limbus, indicating that on this small diameter cornea, this 14.8 millimeter lens is probably going to create an adequate amount of limbal clearance. Whereas in this cornea here on the right, you could see that those limbal markers are in the area of the peripheral corneal clearance zone. We're just going to have to fit this patient with a larger diameter lens so as to be able to create that desired corneal clearance and limbal clearance. Now we can attempt to jettison these areas up, but again, we're really probably best served by going to the larger diameter lens. Now, the 15.5 and up diameter lenses, such as the 16.3 lenses in the diagnostic set, all come with a 125 micron differential in the back of the lens, creating then a toric periphery to the contact lens. This was really discovered in studies that we did at Pacific University, where we found that on 16.3 diameter lenses, the average amount of difference in height between the two principal flat and steep meridians was 125 microns. So that becomes the standard for those larger diameter lenses. Now, both the 14.8 and 16.3 can be made toric, but the 14.8, again, in studies we did at Pacific University, showed that the peripheral, the sclera at that point of landing was essentially spherical. So once again, we don't usually need to use a toric periphery with the 14.8 configuration. So that is not the case with the larger diameter lenses. Those very frequently need to incorporate a toric periphery. And that is why the standard is the 125 micron differential that we see right here. So what we're seeing are those markers that are incorporated into the periphery of the 16.3 diagnostic set, which identify the lowest or the highest meridian, and that is the flat corneal meridian, or I better say the flat scleral meridian. Once again, these numbers were not arbitrarily chosen. They were some backbreaking work done by our researchers at Pacific University that evaluated a large number of corneas to actually come up with these all-important scleral radii data. Now, the ICD FlexFit is also available in a quadrant-specific lens design. This is how that is used. We identify where that flat meridian is located. We communicate that information to the laboratory, and now we can adjust that landing of the contact lens 360 degrees around the lens by virtue of these 4 quadrants. So this gives us tremendous flexibility in our lens designs that we never had before. So very excited about the quadrant specific aspects of this lens design. Now, that can be used by virtue of understanding this study. This is another study done at Pacific University where we measured the sagittal height along the 8 principal meridians of the cornea and sclera. And when we use those numbers, we see that once a lens is applied to the eye, if it's a right eye, the lens frequently goes down in temporal, and the left eye, again, slightly down and temporal as well. This is by virtue of the sheer shape of the human sclera. So understanding these numbers was very, very important in the evolution of our final ICD lens design, the multifocal design. This is a lens that is based on the fact that when we apply a scleral lens to the eye, it frequently decenters temporally. Now, if you're incorporating a multifocal optic into the center of the lens, this means that the multifocal optic is also going to move slightly temporal. But today we know that the human line of sight is not located temporally, but it's actually located nasally. So what we've done here in this little cartoon to clear this up for you is we have marked the geometric center of this scleral lens here on top. We've marked the geometric center of the cornea, and over on the right in the green, we have the human line of sight, exactly where you want that optic to position, not in the center of the cornea, but over the line of sight. Now, watch as the scleral lens drops down. You'll notice here right away that the sclera is shaped very different on the nasal side versus the temporal side. This was a body of work done by Chad Rosen at Pacific University, which was some landmark work that showed us this great discrepancy. Now, as the lens comes down, it's going to hit the higher nasal sclera, and it has to find its equilibrium. And now the actual optic of the lens is even further away from the line of sight. Now, we think that this dislocation of the contact lens is related to the insertion of the medial rectus muscle, which, as you can see here, is closest to the limbus, only 5.8 millimeters away from the limbus. Is that altering the nasal scleral shape, driving the scleral lens to the temporal side? Well, we don't know for sure, but this is pretty high on our suspect list. So what this means is that to really take maximum effect of the optic of a multifocal scleral lens like the ICD, we're going to have to decenter that optic and place it over the line of sight. And that is exactly what is available today. The ability to decenter these optics and place them over the line of sight. Here we see a symmetrical optic, and here we see the same eye with the displaced optic. You can see a significant difference in the quality of the multifocal optic that you're going to see. So being able to communicate to the laboratory exactly where you want the position requires that you communicate closely with the consultants. They'll be able to walk you through how the steps are taken to estimate the amount of decentration of that optic, both nasally and any vertical decentration of the lens that needs to be incorporated. Well, ladies and gentlemen, that is it. That is the ICD FlexFit lens. It has some incredible capabilities to it, and I think you're really going to enjoy working with it in clinical practice. Now, once again, I want to thank the great people at Precision Technology in Vancouver, Cardinal Contact Lens in Ontario for just making this available to us. We need to do more things like this so we can update you on the latest and greatest related to these lenses. With that, thank you very much for your kind attention.